gene mutation mechanisms in some genetic forms of DEE impact the clinical phenotype and choice of treatment. And also, already we have novel therapies, but the potential for development of further novel therapies. I'm also going to discuss the importance of certain pathways, and I'm going to use the MTOR pathway as an exemplar in epileptic encephalopathy. And I'm also going to mention some current gaps in care for many individuals living with EE and DEE. As I'm a clinician, I'm actually going to start and spend about 15 minutes sharing some cases that have taught me a lot over the years. And at the end of the talk, we'll come back to these cases. So the first is a 4-year-old girl, Juliette, whom I met in the neonatal period. Her mum and sibling, whom I follow, has TSC2. An antenatal diagnosis was made on ultrasound at 30 weeks based on the presence of cardiac rhabdomyomas, and one of which obstructed the tricuspid valve. She also had an antenatal arrhythmia requiring treatment with flecainide. In the newborn period, she was referred to the TSC clinic, and on exam, she had hypopigmented macules, but an otherwise normal neurologic exam. Her MRI demonstrated multiple tubers and subependymal nodules. An EEG in the neonatal period was essentially normal, demonstrating some sharp transients. An EEG at 3 months was normal, and an EEG at 4 months demonstrated right temporal occipital spikes. Following discussion with the family, she had not developed any clinical seizures. We discussed that her risk of developing epilepsy with an abnormal EEG was of the order of 90 to 100%. Parents elected to start vigabatrin, and we treated her with 50 milligrams per kilogram per day for 6 months. She did not develop clinical seizures, and her EEG was abnormal at the end of that 6-month period, and I then switched her to lamotrigine, and we kept her on low-dose lamotrigine for a couple of years. She never developed clinical seizures. She's currently 4 years old, and her most recent EEG shows bifrontal delta and rare right temporal sharp waves. In terms of her development, she has minimally delayed expressive language and no evidence of autism. And as we know in TSC, the risk of developing autism is of the order of 40%. The second is an infant followed, who was a 5-year-old who was first seen as an infant and is followed by my colleague, Dr. Linda Ha. And this child developed seizures on the 3rd day of life. And these were multifocal seizures, fitting really the syndrome of early infantile epilepsy with multifocal seizures. Treatment with phenobarbital, levetiracetam, topiramate, and midazolam were ineffective. She required intubation because there was apnea with the seizures. Phenytoin was used and did help, but there was difficulty maintaining levels. Extensive investigations, including MRI, metabolic screening, was negative. Whole exome sequencing demonstrated a de novo gain of function mutation in the FGF12 gene at 1 month of age. We know that FGF12 modulates the activity of sodium channels. She was started on carbamazepine and has been seizure-free since, and her development is normal. In contrast, George is now 26 months old, and I met him in the neonatal period. He was born following a pregnancy where there was exposure to sertraline. He was born at term, there were normal APGAR scores and no immediate perinatal problems. But on the 3rd day of life, he developed multifocal seizures. And again, he fitted the syndrome of early infantile multifocal, epilepsy of infancy with multifocal seizures. Family history was negative. He failed multiple anti-seizure medications. His EEG demonstrated multifocal slowing and multifocal spikes and multifocal seizures. Extensive investigations were negative, and whole exome sequencing at 3 weeks of age, we had a diagnosis of a de novo missense variant in the SCN2A gene. He was discharged from the nursery on 3 anti-seizure medications, and over time I weaned off lacosamide and topiramate and maintained him on phenytoin. He had very rare brief focal seizures between 1 and 7 months of age. He then was seizure-free since 7 months of age, and I electively switched him to oxcarbazepine in order to prevent the negative effects of phenytoin on brain development. Unfortunately, despite very early diagnosis and very good seizure control, and an EEG that just shows occasional mid-central spikes, his development is markedly delayed. He's unable to roll over, he's hypotonic, and has no speech. So in this child, why is his development so delayed with early diagnosis, good seizure control, and a mildly abnormal EEG? And we learn why as we discuss the mechanisms in SCN2A epilepsies. Cassie presented at 9 months of age with epilepsia partialis continua involving the left arm. Her development was normal. There was a strong history of febrile seizures on the paternal side of the family. She failed 5 anti-seizure medications. Again, extensive investigations and chromosome microarray were normal. Whole exome sequencing demonstrated that she had inherited a heterozygous mutation in POG from each parent. A diagnosis of Alport syndrome was made. Valproic acid was not used, but despite this, the child went on to develop hepatic failure and succumbed from that. James is a child who had a Dravet phenotype. He is now 5 years old. He presented with hemiclonic seizures at 3 months of age, affecting the right or left side of the body, followed by Todd's paresis that often would last several days. He had global developmental delay of a mild degree. He developed mild right hemiparesis following a prolonged seizure at 3.5 years of age that persisted. Seizures did not respond to 4 anti-seizure medications, and extensive investigations were negative. He was in our exome study led by my colleague, Dr. Demos, and was demonstrated to have a variant in the ATP1A2 gene, which is known to be associated with hemiplegic migraine. Flunarizine was started and other anti-seizure medications discontinued, and since then he's been seizure-free with no recurrence of the episodes of hemiparesis. Claire, whom I saw yesterday in follow-up, is 9 years old, and she has CSWS. She had a very interesting presentation. I saw her on call at 3 years and 4 months when she presented with a 2-day history of intermittent ataxia and also a possible seizure 2 weeks earlier. Her background was unremarkable. There was no family history of epilepsy, migraine, or ataxia. She incidentally had 4 maternal granduncles with Huntington's disease. So there was a lot of anxiety about neurologic diseases in this family. Her examination revealed just intermittent unsteadiness. MR imaging metabolic testing was negative. Her EEG demonstrated extremely frequent centrotemporal spikes with a dipole configuration independently in both hemispheres. And this is her EEG. And I planned to start her on valproic acid actually, but parents, we discussed medications that would reduce enterical discharges, and parents elected to use ethosuximide. And interestingly, the ataxia resolved almost immediately. Over the years, she's had very rare clinical seizures. She was admitted with a cluster of seizures in December 29 in 2020. However, her EEG abnormalities persisted, but she had no regression. And recent neuropsychological testing demonstrates that she has inattentive type attention deficit disorder and a learning disability in math. I added sulfium to ethosuximide. And when we investigated her, we found that she had a 16p13.3 deletion, and this included the GRIN2A gene. I have an adult, I guess we have some adult neurologists in the audience, and I met Samuel when he was 3.5 years old when I started my training in neurology. And so he was a developmentally normal child, really cute. At 3.5 years of age, he developed multiple seizure types, atypical absence, tonic seizures, and had many, many episodes of non-convulsive status epilepticus. His EEG showed the classical findings of Lennox-Gastaut syndrome with sharp and slow wave complexes, maximal in the bifrontal regions, and bursts of rhythmic fast activity in sleep. Sadly, he failed 30 anti-seizure therapies. The ketogenic diet was ineffective. Corpus callosotomy was very effective in stopping the tonic seizures and the falls. However, he had focal tonic seizures following this. Vagus nerve stimulation reduced his atypical absences and non-convulsive status epilepticus. And actually on this graph, I show you between 1990 and 2004, he was hospitalized with non-convulsive status for 1,368 days. Many of our residents and fellows at that time learned about non-convulsive status from this young man. Unfortunately, as every new investigation became available, chromosome microarray, urine purines and pyrimidines, every new metabolic test, CSF neurotransmitters, we did them. Whole exome sequencing has been negative, whole genome sequencing is negative. And so we're left with this young man with Lennox-Gastaut syndrome, where we have not found an etiology. Clinically, he has dementia and he has severe obsessive compulsive disorder. My final patient, I met at 2 weeks of age, and we did not get a diagnosis until she was 19 years of age. She presented with epileptic spasms and focal motor seizures and responded to vigabatrin. At 18 months, she developed focal motor seizures, focal unaware seizures, and failed 13 anti-seizure medications. I evaluated her for epilepsy surgery, and we were unable to localize the area of seizure onset. A sister had language delay, and in terms of development, this child has quite a marked speech dyspraxia. She has moderate intellectual disability and autism spectrum disorder. Multiple 1.5 and 3 TMR studies were negative. PET was negative. Her EEGs showed multifocal slowing and multifocal epileptiform discharges. And at 19 years of age, again, she was in our study of whole exome sequencing. We found a de novo variant in the DEPDC5 gene. So the concept of epileptic encephalopathy was introduced by the ILE in 2010 and defined as the epileptiform activity itself contributing to the severe and cognitive behavioral impairments beyond that expected from the underlying pathology alone. It results in developmental slowing, often regression, which can occur on a background of normal development or pre-existing developmental delay. And clearly there's an insult to a developing nervous system at the time of network formation. The majority begin in infancy and childhood. The classical example is Landau-Kleffner syndrome, and in fact 30% of patients with Landau-Kleffner syndrome do not have clinical seizures, and when seizures occur, they are usually easily controlled. The sleep EEG shows continuous spike wave in at least 85% of the non-REM sleep recording. Typically, there's marked regression due to auditory agnosia, and behavior problems are common. Now, the concept of developmental and epileptic encephalopathy differs from epileptic encephalopathy. It refers to developmental delay or intellectual disability, representing a static disability, the degree of which may be evident with age. There's a higher risk of epilepsy than in the general population, but not all patients develop epilepsy. And if they do, they cannot always be classified as having a particular epilepsy syndrome. It's important to recognize the development of an epileptic encephalopathy because of the potential impact to intervene and improve outcome. So in the 2017 revision of the ILA classification, epileptic encephalopathy was modified to developmental and epileptic encephalopathy, which from now on I will just call DEE. Many of the genes causing epileptic encephalopathy are recognized independently to adversely impact development. So for example, loss of function SCN2A mutations are a common cause of autism spectrum disorder, often without epilepsy. In contrast, gain of function SCN2A mutations typically cause a DEE beginning under 3 months of age. It can be difficult to differentiate the relative contribution to the developmental part versus the epilepsy part, and this is particularly the case if you have neonatal or early infancy onset of seizures. There has to be evidence for a direct pathogenic variant on development. So for example, in STX-BP1, developmental delay is seen prior to onset of epilepsy, and not all patients develop epilepsy. And as exemplified by my patient with the SCN2A mutation, even if seizures are controlled rapidly, many of these children are severely delayed developmentally. There's also an overlap in genes and pathways in neurodevelopmental disorder, that is in DEE, intellectual disability, developmental delay, and autism spectrum disorder. There's a high rate of de novo mutations in DEE, and more de novo variants in ion channel genes compared with neurodevelopmental disorders without epilepsy. Now, it's important to know where the genes are expressed and also their impact on pathways. So for example, genes can be expressed in inhibitory or excitatory neurons or both, in astrocytes, in the blood-brain barrier, Ion channel involvement can be pre or post-synaptic. Exocytosis, endocytosis, transcription, translation, and DNA repair are also other ways that genes or things that can be influenced by genes. In this schema from Ingrid Shepard's paper published in the European Journal of Pediatric Neurology last year, this shows the spectrum of developmental and DEEs. And if we look at the early onset, focal brain lesions such as hypothalamic hamartomas, hemimegalencephaly, TSC, and focal cortical dysplasia can present really at any age. Ohtahara syndrome, early myoclonic encephalopathy, epilepsy of infancy with migrating focal seizures tend to present early, followed by West syndrome, Dravet syndrome, and then we have Rasmussen's, Lennox-Gastaut, the epilepsy aphasia spectrum, and myoclonic atonic epilepsy. It's also important to know the variant type and gene function. I'm not a geneticist, but I'll try to explain this as a clinician. Copy number variants tend to be greater than 50 base pairs and are either deletions or duplications of one or more genes. Indels or insertions and deletions tend to be less than 50 base pairs. You can have single nucleotide variants that can be frame shift, splice site, stop gain, or stop loss, and these are likely to predict gene disruption. Missense mutations can be gain of function, loss of function, and have a dominant negative effect. And in the DEE group, it's enriched for genes that are sensitive to dominant negative or gain of function effects. The development of targeted therapies for DEEs requires understanding of the genetic mechanisms and the type of cells affected, whether they're excitatory or inhibitory neurons or astrocytes, and also on the variant type, and then the downstream effects. And we know that different variant types in the same gene can be associated with many different phenotypes. If we look at the spectrum of SCN1A related epilepsies, and we're very familiar as pediatric neurologists with Dravet syndrome, but you can have a mild phenotype with generalized epilepsy with febrile seizures plus. Many of these patients have very well controlled seizures, or some of them don't even need to be on an anti-seizure medication. In contrast, in Dravet syndrome, loss of function variants are expressed on inhibitory neurons, leading to loss of inhibition and hyperexcitability. And there's a lot of research and new developments in the treatment of Dravet syndrome. Lynette Sadlier, one of our former fellows who's in New Zealand, and Ingrid Sheffer and colleagues described an early profound epileptic encephalopathy due to threonine 226 methionine phenotype. Seizure onset in this group was less than 3 months, and they typically had epileptic spasms, tonic seizures, a movement disorder, and severe to profound developmental delay. They had a gain of function mutation resulting in depolarizing block, and there's some evidence that sodium channel blockers may help, but still the development tends to be profoundly delayed. Also, hemiplegic migraine has been described with a gain of function SCN1A mutation. With regard to the SCN2A related epilepsies, SCN2A is expressed on excitatory neurons. There's a group that begin under 3 months of age. There's a benign familial, neonatal, and infantile seizures, or you can have a very severe syndrome with Ohtahara syndrome with burst suppression, or early epilepsy of infancy with multifocal seizures or migrating focal seizures. They can have a good response to sodium channel blockers, and there's commonly a missense mutation with gain of function correlating with clinical severity. There's a second group that begins after 3 months of age, and the several epilepsy syndromes have been described, including West syndrome, Lennox-Gastaut syndrome, MAE, focal epilepsy, ESES or CSWS, and unclassified epilepsy. You can also have a presentation of intellectual disability or autism without epilepsy. There tends to be a poor response to sodium channel blockers and a loss of function variant. In terms of the SCN8A epilepsies, SCN8A is expressed on excitatory neurons. You can have de novo gain of function and loss of function mutations in patients with intellectual disability and epilepsy, and this was first described in 2015. There's also a benign form with benign infantile seizures, and also paroxysmal dyskinesia caused by SCN8A mutations. Loss of function mutations are associated with intellectual disability and autism. There have been it's been posed possibly with ataxia, and gain of function mutations associated with an onset of epilepsy after 3 months. A good effect of sodium channel blockers has been demonstrated retrospectively in some patients and in vitro and mouse models, but this has not really been proven to have a big impact on outcome. In terms of treatment of SCN8A epilepsy, our current sodium channel blockers are not selective. And a local company here in Vancouver, Xenon Pharmaceuticals, have developed a product, Xenon 901, a novel selective NaV1.6 inhibitor, and human phase 1 studies to assess safety, tolerability, and pharmacokinetics have happened. And there's currently an adult focal epilepsy trial which we're part of, and a study in SCN8A related DEE, which is about to start, I understand. The KCNQ2 epilepsies, KCNQ2 is expressed in inhibitory and excitatory neurons. KCNQ2 dampens neuronal hyperexcitability, and potassium channels have an important inhibitory role over neuronal firing in the central nervous system. There's repolarization of membranes to end the action potential. Potassium channel openers would decrease hyperexcitability in the brain. The spectrum of the KCNQ2 epilepsies includes benign familial neonatal epilepsy, and this is one of the most common cause of benign familial neonatal epilepsy. This can be inherited, familial, or sporadic. The pathogenic variants can be missense, splice site, frame shift, or whole gene deletions. They can be positioned throughout the gene, and they have a 25 to 50% reduction in current. In contrast, you can also see a very severe DEE with KCNQ2 mutations. These tend to be de novo mutations. They're nearly all missense, and they tend to be clustered in functionally important parts of the protein. They cause greater than 50% reduction of current, and clinically, you can see neonatal non-epileptic myoclonus and epileptic spasms without preceding neonatal seizures. But typically, there's a very severe neonatal onset epileptic encephalopathy, or DEE. There was great excitement with Azogabine and Metagabine, which potentiate the Kv7 mediated potassium current. Unfortunately, challenges arose. This caused a reversible blue discoloration and was withdrawn from the market in 2017. There were anecdotal reports of excellent efficacy in KCNQ2 DEE treated with Metagabine. Again, Xenon Pharmaceuticals here in Vancouver have developed a product which called XEN496, and this is going to be trialed in 40 patients with KCNQ2 DEE from infancy up to the age of 6 years. This graph is really totally out of date. This is the timeline of epilepsy discovery from the first gene discovery by Ingrid Scheffer and colleagues in Melbourne with the acetylcholine receptor gene in autosomal dominant frontal lobe epilepsy. And weekly there are new genes discovered, and it's absolutely impossible as a clinician to keep up. However, in this study from Scotland by Simmons and colleagues, they found that over 50% of diagnoses involved seven genes. The most common was SCN1A, followed by KCNQ2, then followed by CDKL5, SCN2A, STXBB1, which is a synaptic gene, KCNT1, and PCDH19. But there's a very long tail, and more genes will be described. Now, in terms of diagnostic yield, this varies depending on the population, but in patients who have epilepsy plus developmental delay or epileptic encephalopathy, the yield is of the order of 30+%. In a study by Peruca, of individuals aged 2 to 74 years, where they used targeted whole exome sequencing. In MRI negative focal epilepsy with a family history of epilepsy, the yield was 12.5%, and DEF-DC5 and SCN1A were the most common. In a study in Vancouver, led by my colleague Michelle Demos, we looked at children with early onset epilepsy of unknown cause with onset in the first 3 years of life, using targeted exome sequencing. A molecular diagnosis of pathogenic or likely pathogenic variants was achieved in 33% of patients. And actually, since then, some variants have been proved to be pathogenic. But this is as the article was published in Frontiers in Neurology. Clinical management changed following the diagnosis in 39% of the patients with a positive West, or overall 13% of patients. There are many disorders where the gene impacts treatment, and many of you will know this, but I'll just go through. So for example, in the POLB-related disorders, you try to avoid valproic acid, but unfortunately, as in our patient, they can't succumb to hepatic failure without being exposed to valproic acid. In the creatine deficiency syndromes, you can use oral creatine, a large neonatal glycine. Dravet, we know we want to avoid carbamazepine, phenytoin, and lamotrigine. We still have very inadequate treatments, but valproate, clobazam, stiripentol, levetiracetam, topiramate, fenfluramine, CBD are more effective. In the gain of function SCN8A, you can use sodium channel blockers, similarly for the gain of function SCN2A patients. In glucose transporter deficiency, the SLC2A1, this is a really important diagnosis not to miss because it can be associated with progressive microcephaly, intellectual impairment. Can begin with the first year of life with multifocal seizures. It's thought that 10% of children with onset of absence under 4 years of age can have this disorder. Although we find that less common in our group, we have not detected that number in our group. And ketogenic diet is the treatment of choice. In PCDH19, clobazam is reported to be more effective. In PRIT, carbamazepine, and obviously in epilepsy with TSC1 and TSC2 mutations, vigabatrin, the ketogenic diet, MTOR inhibitors. In our patient where we found a Dravet phenotype with an ATP1A3, flunarizine, a calcium channel drug is the treatment of choice. Obviously, we've, as pediatricians or pediatric neurologists, we must always keep in mind the very large group of treatable metabolic disorders that we don't want to miss, and that list keeps growing. And now I'm going to change track a little and talk about TSC as a model for epileptic encephalopathy. As we know, TSC is an autosomal dominant multisystem disease with mTOR overactivation. And epilepsy occurs in 80 to 90% of patients, and seizure onset is in the first year of life in 68% of patients, typically with epileptic spasms and focal seizures. And epilepsy is more common with TSC2 mutations, and TSC2 mutations occur 6 times more commonly than TSC1 mutations. The mTOR pathway, this is well known to many of you, but the mTOR plays an important role in the regulation of cell division, growth, and survival. And thus, aberrant activation of the cascade during cortical development can cause dramatic alterations in cell size, cortical lamination, axon, and dendrite growth. And over the past decade, enhanced activation of the mTOR pathway has been identified in malformations of cortical development, as well as in tuberous sclerosis complex. We have specific treatments for epilepsy in TSC. Vigabatrin is the treatment of choice for epileptic spasms and focal seizures in the first year of life. The ketogenic diet also has mTOR inhibition. Then the mTOR inhibitors have been demonstrated to be effective for the treatment of SEGAs and AMLs. And in animal studies, they have suppressed the development of SEGAs and AMLs and also development of tubers in a mouse model. In the EXIST-3 trial published in 2016 in children and adults with treatment-resistant epilepsy and tuberous sclerosis complex, in the high-dose group, 40% experienced a greater than 50% reduction in seizures versus 20% 28% in the low dose group. Obviously, epilepsy surgery is a treatment for carefully selected patients. And more recently, we have preemptive treatment. But in order to have preemptive treatment, as in my first case, Juliette, that I presented, the patients need to be referred to a neurologist early. Typically, patients are referred after infantile spasms or focal seizures have developed. So the first paper that brought to our attention the potential to have preventative treatment was published by Józwiak from Poland. He studied 45 infants with TSC, 31 of whom had standard treatment after seizure onset, and 14 had preventative treatment after intraictal epileptiform discharges were found on EEG. They were followed until age 2. And in the standard group, 35% were seizure-free versus 93% in the preventative group. Developmental delay occurred in 48% of the standard treated group versus 14% in the preventative group. And the mean IQ was 92 in the preventative group versus 69 in the standard group. This resulted in a prospective study in Europe, and recruitment was difficult actually because there was termination of a lot of pregnancies when TSC was detected. And then there's been a prospective study led by in the States by Dr. Bevan. But the EEG is a biomarker in TSC. In this study in the States, they looked at infants with TSC under 7 months without seizures. They had serial examinations, video EEG, and education of parents about the clinical features of focal seizures and epileptic spasms. If seizures occurred, standard treatment was used, and developmental assessments were performed at 6, 12, and 24 months. 40 children were enrolled, and 28 were over 12 months at the time of analysis. 67.8% developed seizures, with epileptic spasms being the most common. 73.6% had their first EEG abnormality at a mean age of 4.3 months. That is 2.8 months before seizure onset. So seizures developed in all children with an abnormal EEG, thus a very high predictive value. 64% with a normal EEG did not develop epilepsy. Hypsarrhythmia was not found before the onset of epileptic spasms. And they concluded that serial routine EEGs is a feasible strategy to identify those at high risk of epilepsy. Now, it's not easy. How frequently do you do the EEGs? Are there resources to be able to do EEGs? And there's lots of questions raised by this. But for the last 5-6 years, if patients are referred to us early, at our centre, we're trying to do serial EEGs. And we try to do it about every 2 months. I now want to really discuss MTOR inhibition in hemimegalencephaly, and this is work from my colleague, Dr. Anita Datta. And Anita had a patient who developed seizures at 6 days of age with epileptic spasms and focal seizures and hemimegalencephaly, as we can see on imaging. This child failed 9 anti-seizure medications and the ketogenic diet. And obviously surgery was being considered, but the infant was very small, and thus that comes with a high risk of intraoperative bleeding and higher mortality. So Anita got ethical approval to use Rapamycin, and in the following schema, seizure frequency is along time is along the x-axis, seizure frequency on the y-axis. These are all the various drug treatments in yellow, the ketogenic diet at the top, and then this is where rapamycin is introduced. And the orange, these are episodes of status epilepticus. This patient often had many, many seizures per hour. And we see when the rapamycin was introduced, there's quite a marked reduction, actually over 50% reduction in seizures, and the status epilepticus was controlled. So at 1 week, there was over 50% reduction in seizure frequency and a decrease in seizure duration. At 2 weeks, the parents reported the child seeming brighter and more interactive. And then the periinsular hemispherotomy was deferred by 2 months to allow the infant to gain weight and to reduce the potential complications of surgery. And I'm happy to say that successful surgery was performed and the outcome has been very good. And I understand the child is still seizure free. Now, in DEP-DC5 epilepsy, we know that DEP-DC5 variants are seen in familial focal epilepsy with variable foci, and very often it's not possible to demonstrate the FCD on MR imaging. The DEP-DC5 knockdown causes mTOR-dependent hyperactivity in zebrafish. Rapamycin used in the mouse model from P12 to 30 in DEP-DC5 epilepsy mouse model prevents seizures and SUDEP by inhibition of the mTOR pathway. And the GATOR pathway, which is a component of the mTOR pathway, is very important. I'm not really going to get into the landscape of epilepsy associated with GATOR variants, but there are some references in my talk that those who want to learn more about it may be interested in. I'd now like to go back to our patients. So firstly, Juliette. So Juliette had tuberous sclerosis complex, diagnosed antenatally. We used preemptive treatment, and she's had a very good neurologic outcome. You could argue maybe she wouldn't have developed seizures, but the study from the States would suggest that the risk of her developing seizures was very high with an abnormal EEG. So I do feel that the strategy we took by using vigabatrin, the risks with vigabatrin for 6 months are very low compared to the risks of having treatment-resistant focal epilepsy and epileptic spasms. Case 2, we found a de novo gain of function in an FGF1/2 gene, which has an downstream effect on sodium channels. Now this, our paper by Guel et al. From our site describes our patient, or Dr. Huss patient, and another patient from Alabama who was diagnosed at a much older age and had a very severe outcome with treatment-resistant epilepsy. There's subsequently been several further patients described in the literature, all of whom have not had a good neurologic outcome. So there's a lot of controversy, but I do think the fact that this child was diagnosed very early has had an impact on her neurologic outcome. My patient that I met in the neonatal period, who turned out to have an SCN2A DEE, despite early diagnosis and excellent seizure control and improvement in the EEG, he's had a very poor neurologic outcome. So clearly the SCN2A gene has an action way beyond the epilepsy in this child. Our patient with EPC and the POL mutation, that guided treatment, but unfortunately we know with POL mutations, the prognosis is very poor and there's a high risk of mortality. Case 5 with the Dravet phenotype, James. This is really to remind us that not all patients with a Dravet phenotype have an SCN1A mutation, and the value of whole exome sequencing in this group. Unfortunately, if he had been diagnosed earlier, perhaps the neurologic outcome would have been better. In our patient with CSWS, who had a very unusual presentation, in the epilepsy aphasia spectrum, carbamazepine is known to worsen seizures. We try to use drugs that would decrease seizure frequency. Valproic acid or high-dose benzodiazepines tend to be first line, followed by steroids. Interestingly, in my patient, valproic acid made the seizures worse. Genes implicated include the GRIN2A, which reduce NMDA receptor trafficking. There can be pathogenic variants resulting in loss of function of the gene. And then the other pathways, the GRIN2A, FOXP2, or PX2 signal network is thought to be important in language deficits. My patient with Lennox-Gastaut syndrome has had a very long and arduous journey. Despite all the advances, we still don't know what the cause of his epileptic encephalopathy, and it's obviously had a very profound impact on his cognitive and psychiatric outcome. In my final case, where we diagnosed a DEP-DC5 cause of her DEE at 19 years of age, I look back and I wonder if we'd had this diagnosis when she was younger, could we have argued to have try an mTOR inhibitor? Might it have had some impact on her seizure control and neurologic outcome? So in conclusion, it is important to look for causes of epileptic encephalopathy and DEE as early as possible, to identify diseases and pathways with specific treatment implications, to avoid treatments that may exacerbate seizure control, and to try to optimize treatment and neurodevelopment, knowing that we may not be able to have an excellent neurodevelopmental outcome despite good seizure control because of the impact of the genes on development. Natural history studies are very important in order to be able to assess the impact of novel therapies. And of course, many patients are undiagnosed. So there's still value in being able to make a diagnosis in older children and adults so that we will have more data on natural history. I think in tuberous sclerosis complex and probably in hemimegalencephaly, preemptive treatment is possible, but it does require early referral, and thus we need to educate pediatricians and obstetricians and others about the importance of early referral. A genetic diagnosis provides a platform for the development of novel therapies, and this is a rapidly developing field. There's the opportunity for disease modification and the potential to restore normal function, especially now with some of the new genetic therapies. And Dr. Sheffer is going to really talk about all the new therapies in her talk, which is coming up in the next couple of months. Collaboration between epileptologists, geneticists, and gene experts is even more important now. I think that I finally like to thank my patients and families who have taught me so much. It's been an absolute pleasure to have such interesting families over the years. I'd like to thank my colleagues and all the staff in our comprehensive epilepsy program. And particularly, I'd like to thank the Albert Foundation and the Pejman family, the parents of a child whom I looked after who raised $800,000 for our genomics research. And with that, I thank you for listening.
Thank you so much, Dr. Connolly. We are in the middle of a significant pandemic. We are all affected by this pandemic one way or the other. It is very important that we stay connected with each other. So the Canadian Epilepsy Teaching Network provides connectivity every month to share our academic interest. So please support each other. Dr. Connolly, you are on the dot, exactly 12:45 Eastern Standard Time. And that shows what sort of a seasoned speaker you are. You're given 45 minutes and you stopped exactly at 45 minutes. So that is what the young generation need to learn. So there are several questions and let me read them for you. Dr. Aline Namani from University of Alberta is an adult neurologist. A child with Lennox-Gastaut syndrome, I think he was referring to your patient, I believe. Did he have whole evolution spectrum of infantile spasm or West syndrome and then into Lennox-Gastaut, or since the first presentation had the phenotype of Lennox-Gastaut syndrome?
Actually, he had no history of neonatal or infantile seizures. His first seizure was at 3.5 years. And actually, for sake of time, I had to be very succinct. He had 30 volumes or more of records from all his hospitalizations, but he actually presented with a few isolated tonic-clonic seizures and was started on carbamazepine. And his initial EEG was normal. And then carbamazepine was stopped, but his EEG since then has shown the classical findings of slow background, sharp and slow wave complexes, and bursts of rhythmic spikes in sleep. And we've documented atypical absences, tonic seizures. And as things have evolved after the callosotomy, his seizure types now are partial focal tonic seizures, which is commonly seen post-callosotomy. So he is one of the children who was really normal. He had actually maybe minimal language delay prior to the onset of his seizures. And so there was a whole group of Lennox-Gastaut patients. The yield from whole exome sequencing is quite low in infantile spasms of unknown cause, and in Lennox-Gastaut, I think it's less than 15%. But if there's some geneticists on, please feel free to correct me on that. But this young man, I'm just amazed that we've not found the cause.
Okay.
Just amazed.
Now we go to Turkey for Isra Serdaroglu. She is a child neurologist and she is asking, will the new drugs for potassium channel be a treatment option for other types of epilepsies?
I apologize. I better look at the chat. I just missed.
It is not the chat, it is in the question and answer. Will the new drugs for potassium channel be a treatment option for other types of epilepsies?
Oh, yes, I'm sure they will. I'm sure they will. But obviously that needs to be determined. You know, there's a study at the moment on, there's an adult focal epilepsy study, and it's more looking too also at tolerability. But I'm sure, yes, the group here, Xenon Pharmaceuticals here in Vancouver, they focus on development of drugs in relation to genes. So they, you know, very, very targeted treatments. And there are many other groups doing similar work. But
yeah,
I'm
so
sure,
apologize.
yes.
The questions are both in the Q&A as well as in the chat. So the next one is lacosamide effective in mutations responding to sodium channel drugs?
It can be, but I don't think there's enough data yet to answer that.
Okay.
Yeah.
So a question from Chennai, India by Dr. Padma Balaji. What is your experience with the epileptic spasms with SCN1A mutation?
I have not seen epileptic spasms. I have one patient with the neonatal onset, but does not have the same gene as described by Lynette Sadlier and her colleagues. It does not have the same mutation, and he has a very severe early onset. Again, the EIMFS phenotype with multifocal seizures, and the still has intractable seizures. But actually, we've tried about 6 medications so far. So I don't have experience of epileptic spasms due to SCN1A.
The next one is from Dr. Robin Whitney from McMaster. She is asking, DEP-DC5 or Gator or patients with a hemimegalencephaly, do you have any experience using vigabatrin in these cases, given some mTOR inhibition, although it is weak?
Yes, I can't tell you the number. We probably have had 5 or 6 babies, you know, with infantile spasms and focal seizures due to hemimegalencephaly, and vigabatrin would be our first treatment. I mean, I actually think it probably should be used prophylactically if you've got hemimegalencephaly, in the same way like TSC, because the risk of developing seizures is almost 100%. And in Dr. Dada's patient, vigabatrin was used early on.
Dr. Carl Klein from Calgary, could you comment on the mechanism how mTOR inhibitors reduce seizure frequency in mTORinopathies by modifying the structural abnormalities, a direct modulation of neuronal excitability, or both?
Oh, actually, I just was reading an article on this last night, but I don't know that we can explain. I don't think that we can explain all this yet in terms of the mechanism.
Okay. Next one is from Isra from Turkey. What do you think about giving mTOR inhibitor therapy in neurofibromatosis type 1?
Okay, well, again, I can't really comment on that. I mean, NF1, you know, epilepsy tends to be not very common and very easy to control, and certainly in my experience and from the literature, it tends to be very easy to control. And then I don't have enough experience in NF1 around the role of an mTOR inhibitor in prevention of complications, you know. So I really, that's outside my area of expertise or knowledge.
Okay. Another one from Dr. Filal. Is PET and SPECT required in epileptic encephalopathies?
I would only use those if I was looking at a surgical option, you know, but not routinely.
Okay. Another question is from Dr. Sridharan from India. What is your experience of using everolimus in TSC?
Okay.
Have you come across any patient who had a new onset behavioral or psychiatric symptoms after starting everolimus?
No, so we were a site in the EXIST-3 study. So I had 4 patients in the study, and one child, he had epileptic spasms, responded to vigabatrin, then developed focal seizures that were treatment resistant. And he was on lamotrigine monotherapy 2 weeks after starting everolimus. He stopped having seizures, and he's not had a single seizure since. And he's on a very small dose of everolimus, and he's at least 4 years out, and still